Welcome back to part 2 of Clinical Correlations Vascular Pathology. In this recording, we'll be going over the anatomy and histology of blood vessels, as well as some of the clinical procedures associated with them. So let's go ahead and talk about the general anatomy and the differences of some of our blood vessels, namely arteries, veins, and capillaries. As we already talked about capillaries when we looked at the AVMs, let's go ahead and just refresh ourselves in that the capillaries, or capillary beds as they tend to form, and you can see here, they call it a capillary network. These are where our nutrient and oxygen exchange occurs among vessels. So we have our arterioles that are eventually going to spread out into the capillary bed, and the capillary bed is eventually going to then give rise to our venules, and it's kind of the exchange process between arteries and veins. And so we want to make sure that we have the maximum amount of surface area. We kind of see the same thing in lungs too when we have our alveoli, these little microscopic structures that just sort of expand and create as many areas of surface that they can in order to maximize the exchange that needs to happen. So next up we have arteries. Now these are structures that are going to be under a decent amount of pressure as they receive blood from the heart, which is constantly pumping, constantly throwing blood against the arterial walls. And so the walls need to be designed to take that pressure and take that continued quote-unquote abuse from the heart. Now that doesn't mean that it's under high pressure, high blood pressure. It just means that it is a pressured system, especially compared to that of the veins. So what we'll notice in our artery structures is that they have a nice thick medial region, which is where our smooth muscle of the vessels is housed. And so this allows for a sort of elastic kind of expanding and contraction motion that as blood kind of exits the heart into the aorta, we get kind of this like reaction as basically the blood expands the vessel and allows it to contract. The muscles kind of create this nice movement to keep blood flowing through the rest of the body, because we want that blood from the heart to get as far as it can to our extremities, everywhere from our brain to our toes. And so that pressure system needs to be maintained effectively throughout. And so we'll see large arteries, which predominantly is our aorta, medium arteries, which are usually things like our renal arteries, and then some small ones, which are sort of a lot of these unnamed arteries that we see among structures in the bodies as they continue to kind of expand and spread throughout. Now after blood passes through the capillaries, we'll get into the venous system, and this is a low pressure system, right? There's nothing really pushing blood into the capillary system. It just sort of happens to end up there after the capillary bed is done with it. And so there's really no high pressure here. That means we don't really see a thick medial region. We don't have a lot of smooth muscle in the walls of our veins. And these vessels tend to be more flexible. So if you actually look at the image here in histology, you'll always notice that veins kind of have this like little collapsed but wide lumen, whereas arteries seem to maintain their structure within these neurovascular bundles that you'll see. Additionally, veins are going to contain valves. And the reason for that is because these low pressure systems, blood would theoretically keep coming back to where it was flowing. So let's say the extremities, for instance, if we were just to kind of stand still, blood naturally wants to follow gravity and it's going to keep going. And to prevent blood basically just pooling in our feet and having nice little purple feet as we walk around, or what you'll really see as varicose veins, these valves are going to prevent that backflow. And so what happens in vein return of the blood is just our kinetic movements is ultimately going to push the blood back into the heart. So these things are tucked into some of our skeletal muscles, and as those continue to move, it basically creates this pumping mechanism which will continue to happen, and the backflow is prevented through the valves until it ultimately reaches the heart and the cycle begins anew. So again, we go from the small, so we don't really have the venules mentioned here, which are immediately after the capillary bed, but then you get the small, usually unnamed one. Medium is most of your named veins that correspond to the corresponding medium arteries, and then the large vein is your vena cavas, the inferior and superior vena cavas. So here you can kind of look at nice little cross sections of our vein and artery system, and kind of going from our nice thick aortic wall as we get thinner and thinner and thinner to our capillary bed, and then going all the way up to our big venal cable system. So again, you notice this nice thick medial region of the blood vessels here in the aorta, and we don't see that in the vein as much. But we do see these venous valves show up, particularly in the named veins, the bigger ones. But notice the thin walls. So these usually are going to kind of appear flattened, histologically speaking, as they make their way back. So you should be able to tell veins versus arteries, histologically speaking. Then we got the flow of our blood going from heart to the extremities and all the way back again through our capillary beds. So histologically speaking, we refer to blood vessels as having 3 layers: the intima, media, and adventitia. And so this should be kind of old news for students if they take structure and function and seen the histology of these things over and over again. But the intima is pretty much the same in every single blood vessel, including capillaries. It's just going to be that inner endothelial lining, inner endothelial lining that you'll see lining the lumen of the blood vessel. So everything will have that, including capillaries. It's just capillaries are pretty much all intima. The media is where our smooth muscle layer is for these. So we talk about the prominent ones being in the arteries and the veins having a very small media. And you can kind of see here, if we were to zoom in, this nice basophilic region. And we even call it nice, it's kind of pathetic, you could argue, but there you can see our medial region in the vein compared to the nice thick one here, right? So you definitely notice the media on the arteries. And then finally, the adventitia is the outer side. So adventitia, we've learned, is pretty much that connective tissue when we don't have it covered by serosa. It's just going to be loose connective tissue for the most part, and in some cases you even have some of this adipose tissue surrounding it as well, which are going to be part of that. So this is going to be the direct outer portion, and what we'll notice is these 3 layers tend to be separated by elastic lamina, and some of these tend to be more prominent in certain vessels than others, but particularly we see the elasticity in arteries being very prominent, so you can actually do elastic stains on these to kind of see nice little, and it looks like they kind of have them here. So you have your internal elastic lamina, and then you would have an external elastic lamina in the arteries as well. So usually those are going to be separated, and that will become prominent when we look at certain pathologies as well, as that description of the separation lines, those laminas between. So rather than going through every single image, just know some of the key differences between basic blood vessels, namely the large arteries, large veins versus the medium artery and veins, small artery and veins, arterioles and venules, and capillaries. So if I were to ask you, which ones have, 8 smooth muscle layers, it'd be small arteries or veins typically, whereas capillaries only have 1 to 2 endothelial cells, no medial layer, and arterioles are quite small with their very thin medial layer of 1 to 2 muscular regions. Medium vessels tend to have more prominent elastic lamina, just because they are kind of taking a bulk of the blood supply. And then in the large artery, we know that the tunica media alternates with smooth muscles and elastic fibers, so making them extra resilient and elastic in a way to receive that blood pumped out of the heart and eventually kind of make its way, or basically repump it by expanding and contracting to the rest of the body. So we have a lot more prominent elastic fibers in the large artery, namely the aorta. We additionally have these vasa vasorum within the adventitia of large vessels that you can usually see. And if you look at cadaveric images, sometimes you see like little white striated vessels on the outside of the blood vessel. Those are basically vasa vasorum, which means blood vessels of blood vessels, which are kind of cool. So you see those on the large arteries. And in the large vein, you have longitudinal smooth muscles in the tunica adventitia. So you usually don't see smooth muscle in the tunica adventitia like you would in the rest of the regions. I've mentioned the word tunica a couple of times, so a lot of times these layers will be designated as tunica intima, tunica media, and tunica adventitia. That really just is a designation of the layer of media, layer of intima, and layer of adventitia. So you'll hear that basically used interchangeably. All right, so now let's take a look at some of the clinical procedures. So back in the olden days, you may have heard stories of things like bloodletting and leeching as primary clinical procedures to treat people who may have had blood issues. And sometimes it's not even blood issues if we're looking at things like the understanding of the 4 humors. So sometimes it was just a matter of, oh, hey, you seem extra angry. Maybe we just need to let out some of that red blood and you'll be calmer. And the truth is you would be calmer because you would basically exsanguinate a little bit of blood and be a little weaker, too weak to fight in that case. So we don't really do processes like this bloodletting anymore. And leeching used to be done kind of in the medieval days. I know you would think about like adding leeches as sort of an old treatment. But interestingly enough, it's kind of made a resurgence in modern medicine, particularly when doing reattachments of particular structures like extremities, skin grafts, and other medical procedures where surgeons are working on a very microscopic level and trying to make sure their blood is continuously flowing, connecting your small arteries and veins, things like that. And leeches can actually be used to help prevent some of the clotting that might occur and result in ischemic conditions if those areas became clotted and unable to allow blood to transfer through due to the nature of injury, right? If you're suturing things together, you always run the risk of potentially causing damage, which could cause platelet formation and deposition, which could ultimately cause clotting. So leeches can still be used. You may see these in modern medicine practices of trying to help reduce clotting because leeches have a natural anticoagulant. But I won't test you on any of these structures, just some fun to know blood procedures. What you do need to know is angiogram. So the basic angiogram is, if you recall back in the imaging lecture, we talked about using these to visualize blood vessels. And what we have had to do here is, because blood vessels don't just naturally show up on x-rays or CT scans because they're soft tissues, we need to put some sort of contrast in. And so they'll just do some sort of radioactive isotope contrast, sometimes like a barium. They can inject it in there, and then they can kind of just see how that spreads out. So you get these nice little images on the CT based off of that contrast medium. What's cool is this looks like our carotid, right? So our carotid body, we got the bifurcation into the external and internal. But what you can see is areas of potential narrowing, right? So if there's a plaque present, sometimes you don't see a full lumen, or there'll be areas where it looks kind of pinpoint, right? So if we look at this carotid body here, extending into the internal, much wider than over here. So maybe that's an area of concern for a plaque that we can go investigate. Additionally, they can use laser Doppler angiography. And what's neat about this is it really just measures the flow of blood. And using that as a conversion, they can basically assign these colored values on how quickly blood is flowing. So as you can imagine, if there is a obstruction or any sort of inhibition of blood flow, that blood speed is going to slow down in those regions, and you start seeing things like this little discoloration here. So green is associated with a slower blood flow compared to the red associated with that. So Doppler can kind of tell you, oh, look, it looks like there's some narrowing here. That might be an area of concern where blood is kind of starting to slow down after the fact because it's trying to get to a region of a plaque or some other obstruction. So you'll see stuff like that. If imaging happened to find something of note in the blood vessels or some sort of blockage, what we can do is use a catheter to do the process of a balloon angioplasty. This is particularly talking about coronary, since those tend to be the more common procedures that are done. But we did see angioplasty could be used for things like fibromuscular dysplasia, as well as anything where you need to expand the lumen or open the lumen of a blood vessel. You can pretty much use this balloon angioplasty process. And so what happens is they're going to stick this catheter in, and they usually do it in the groin region, a lot of times the femoral artery. So they're going to go all the way up, and so you can imagine, especially if we're trying to get to the coronary, that can be quite the process there. The reasons for that can just be, you're trying to inject something in a arterial supply, so you don't want to do it real close to the heart, like the aorta, damaging that wall, because it's under a lot of pressure, and we don't want to do damage to a blood vessel that needs to be, the integrity needs to be intact. So they'll go up through the groin region, and in just a balloon angioplasty, what they'll do is come up to the site of impact, where there might be a plaque or some sort of stenosis occurring. They'll expand the balloon, and then they can kind of retract the catheter, and that's ideally going to just compress the plaque and widen the lumen, essentially for use again. Now, if there is a significant blockage or recurrence of blockage, what they can do is use a stent placement, which follows the same procedure, except there's a little wire mesh stent wrapped around the balloon, and you can kind of see how this is sort of compacted initially around the balloon, and then when the balloon expands, the wire mesh expands with it. The balloon can then compress and be withdrawn while the stent remains in place. Now, typically these stents are going to be medicated with something that will help try to basically minimize the blockage and remove the plaque, as well as making sure that the blood vessel doesn't react poorly to it. So these are usually medically coded for that. But we do have a video we can look at real quick just to kind of get an understanding of how that process would work.
It is gently and easily deployed over the thrombotic lesion by retracting a protective sheath, and because of its inherent design and properties, it exhibits no recoil. As spasm is relieved, the vessel diameter increases, and the stent follows in expansion and continues its scaffolding of the artery. Finally, as the thrombus dissolves, the stent expands further to absorb the gap left by the dissolving thrombus, thus maintaining a perfect apposition throughout the remodeling process of the vessel. This allows the free mesh to cover the side branch ostium. The wide opening provides uncompromised access to the side branch for optional further treatment. The shape memory properties of nitinol make the disconnected ends return to their initial position and safely appose to the vessel wall.